And I think we're live.
Perfect. Hey, Sharon, how you doing today?
Well, at least I'm on today, right?
I know you're on today, and I'm the one with the technical issues, but we're here. So let's dive right in, Sharon. Since we only have 10 minutes for these talks, we'll probably go a little bit over because today is super interesting. We're gonna go over the article that I sent you that I thought, applies to you as a survivor of breast cancer, but also applies to so much of what we're doing. So I put it down, I linked it in the comments, the actual study, as well as the summary of the study by Ohio State University and a researcher named 𝘠𝘪𝘨𝘏𝘠. I hope I'm saying her name right. But the title of the study is Obstacles for Breast Cancer Prevention in High-Risk Black Women. New study finds multiple hurdles, competing priorities. I want to just stop here, Sharon, because I know you have posted your recent talk that you did in the Memphis meeting about your own journey with breast cancer from kind of the diagnosis perspective and then the early interventions with your doctors. And you had an incredible, for any standard, an incredible team working with you for your breast cancer. So maybe let's start with what goes right.
Yes.
Because I think we focus so much on what goes wrong, obviously, because the consequences of what goes wrong are so intense. But when things go right, maybe spend a couple minutes talking about your experience and that this really is the ideal experience.
Yeah. Thanks for that. I had a conversation yesterday with someone, Sarah, and they said to me, well, I think your experience went right because you're an educated woman. And I said, well, yes and no, because a PhD or a master's or a college degree would not have, it doesn't make a difference when it comes to cancer. But what makes a difference is being educated about cancer. And that's the reason why, here at Total Health Education, we're trying to really get that word out. So that part of it is where I would like to start.
Yeah.
Being educated about the disease, because when you have the disease, it's not the time to become educated because you're in distress and despair. So for me, as a woman who I have dense breast tissue. So for the past 10 years, I've always had the twice per year test. So I was educating myself along the way as to, okay, what could and could not happen. And part of the reason for even me getting the diagnosis early is because of my 6-month windows.
Right.
And so I put that responsibility on the patient. But then also, too, the care team. Gosh, having the right care team
makes all the difference.
I cannot stress it anymore. It makes all the difference in the world to have that empathetic, knowledgeable, cutting edge team. It makes.
Now, Sharon, were you treated in an academic center or in the community?
Community.
I mean, I love it. Look, 85% of patients with a new cancer diagnosis are treated in the community.
Yeah.
We tend to think you get the best care in academic centers, and maybe that's true for rare cancers, or if you're lucky enough to live close to one, because it's like all their services are under one roof and they've got the greatest research and all the rest. But I mean, you're a living testament to the power of community care.
Yes, yes. And one of the things I said in Memphis is that even if you don't belong to a group, like my doctors were all part of a group. So they had the record sharing, it was pretty seamless, right? And we're all on these, digital space. But even if you're not, I would just suggest that doctors really network and connect with those caregivers that are complementary to the primary care to make it a lot more cohesive for the patient, because it made a difference to me that every doctor knew exactly where I was in the process.
Yeah, no, I think that is what makes the difference when you have that multidisciplinary team approach and that everybody is aware of each other's roles and intervention. And like you said, the patient is educated. I was reading on a post, Laura Esserman, who's this, incredible breast cancer researcher and clinician. And she was recently interviewing this Black woman. I want to say her name is Karen, and it was like Karen's story or something. I'll see if I can find the link and I'll post it. But I commented on it because Dr. Esserman was saying, like, you know, you have to be like this patient. She kind of broke down all of these barriers, and, you know, this is why she's here today. And I thought, what an incredible, empowering story of this patient. But I posted, like, we shouldn't have to be trailblazers to get great care. Like, we as the patient shouldn't have to know how to be our best advocate in order to kind of have these standards of care, or to expect these standards of care. And I think that's one of the things that the article gets into. I want to get into it a little bit with you, because first, let me give you some stats. And again, I know we don't have a lot of time, but right now, according to the SEER database, which is the national database that records cancers in the US, there's about 330,000 Black women either surviving or living with breast cancer in the US at this moment, 330,000. Breast cancer is the most common cancer among Black women. Black women are diagnosed at younger ages with more aggressive, later stage disease. There is a 40% higher death rate for a Black woman living with breast cancer than a white woman. And people of color, period, represent less than 3% of all clinical trial participants. And I think if you remember in my talk, given at it's 3% of 5% of all comers. So, I mean, it's dismal. But this study, Sharon said, which there were so many interesting things. I really encourage our listeners to just, it's a quick read, but it's such a powerful read. She said that the article summarizes, the researchers found several differences based on race, all which pointed to potentially worse outcomes. Black women were described as feeling less ready and equipped to consider and cope with their risk, and less informed about their options. Maybe speak to that. Like, what's going on that a whole kind of race of people are feeling less ready and equipped and less informed to deal with their disease?
I read that too. You know, I printed out some of this stuff. So on the patient side, and especially on the cultural Black patient side, I'm not trying to speak for the entire Black race, but this is what I know as a Black woman, and also a Black woman in a family of other Black women. So there is this article said they were less ready and able to cope. And I do see that denial aspect, cultural denial. For example, there are family members that I know that will not have a mammogram. And
is it because it's like, if I don't know it, it's not there? Like, what is it?
It's a little bit of that. If I don't know it, it's not there. Secondly, too, you know, that there's this whole history of distrust of the medical system with Blacks. You know, there's like this, you know, this overarching distrust that we won't get the best care. We will be told a wrong diagnosis. So there's all these misconceptions that we have to break down. But there is that thing about less ready to cope. And of course, we know also about some of the economics on the insurance. And all of that, you know, all of that, those factors as well.
Well, wait, Sharon, I mean, let's talk about that for a second. In this study of, I think they studied 50 women, or they questioned 50 women, it was almost like half. The Black women in the study, 40% experienced a time without insurance. Listen to this, compared to just 3% of the white women. And 40% of the Black women also described significant financial difficulties coping with health challenges, compared to 3% of whites.
So there's economics. There is economics, and we can't deny that, right? I read something earlier today too. I think you might have posted it somewhere about, even when you have insurance, and you're Black, you get denied 40% more if you're Black for claims. So this creates like a huge distrust in the system. Like, why pay for insurance then if I'm going to be denied 40% higher? So it's this never-ending loop of, I don't trust you, and okay, because, you know, and then I'm not going to give you service.
Yeah,
So
it's like Dr. Mitchell said at the conference. We need to stop saying Black people don't trust us. We need to start becoming trustworthy to Black people. I
yes,
thought that was it was like flipping the narrative, because it's so easy for us to be like, oh, it's others, it's others, it's others. But when you really put the focus back on yourself, you're like, wait a second, it starts with me. What am I doing to earn people's trust? So, you know, it kind of puts the onus of responsibility on the caregiver.
and that's why. And Sarah, you may want to look at the screen and maybe answer Jane's question. But I am very excited about what we're trying to do, Sarah, through total health education with the doctors, with the care, with the healthcare providers. Educating them about disparities, about, okay, how do you approach a Black patient compared to maybe how you approach a white patient? Because there's education needed on the doctor's side. And then we also need to work on the patient side as well to help to build that bridge. That's something I'm very excited and passionate about at this moment, because if we don't fix that, if we don't address that, we're going to keep having these conversations and keep having these numbers. We have to find some common ground. Like you said, the doctors have to come a little bit more. Hey, understand.
A lot more.
Stop with the nonsense.
Yeah.
I mentioned in my speech that, all my doctors were white, right?
Yeah.
Except for maybe one doctor. And I was treated exceptionally. Now, is it luck? I don't know. But I'm a very, very informed patient.
Yeah.
I know my rights. I know I demand a certain level of respect. And I believe this is something that we want to help our Black patients to become really educated and take their healthcare in their hands.
Yeah.
That is their secret weapon if they know what to ask. I think.
Yeah, and it's so interesting too, because it's really not. I mean, this particular study is talking about Black and white, but it really isn't a Black and white issue, right? It's Hispanics with a language barrier. We learned Pacific Islanders are the second greatest mortality. Like, it's almost an invisible, Native peoples, Pacific Islanders, it's almost an invisible population.
Yes.
And then that stat, I wish I had it at my hands, but LGBTQ people are almost right away, not even from the system designed to support them, but from people. It's like, you don't even know necessarily how to relate, which leads to worse outcomes. But it's so interesting, all of the different factors. But I think you're right. I mean, people have to come to the table seeking the solutions. I just want to take a second for the question. I'm wondering about, before they're diagnosed, should they get genetic testing? So, in the higher kind of genetic risk cancers, like triple negative breast cancer in the Black population, there still isn't guidance that moves beyond what we know, like known family risk and then age. It's not like if you're sitting in front of a Black patient, this is a trigger for you to order a genetic test.
Right.
But should it be? I mean, these are some of the things that we have to start asking ourselves. If people are being diagnosed at greater rates and dying at greater rates, should we start talking about fundamentally changing the way we almost like screen through these patients to give them the best outcomes? But that's probably a great question for when Dr. Matani joins us. But there is no rationale to genetic testing populations because of their race at this time, because what you find may not be actionable, or what you don't find may not lead to different outcomes. But one more thing, Sharon, if we could just focus on in this article before we close, this really, I mean, both of us are Christian women.
Yes.
This piece really blew me away in a mixed feelings way. So it said many white women in the study were more inclined to pursue preventive medications such as tamoxifen, prophylactic mastectomies, and they told the researchers they perceived themselves to be at specific risk. This was like why they had these behaviors, because they worried a lot about their cancer. In contrast, Black women who worried about their risk were more likely to talk about their faith. Yes. And then it kind of spins into this, I don't know, for me, it was really weird, because it spun into this, while worrying less and having strong spiritual connection could have mental health benefits for Black women, it also could serve as a barrier to seeking out risk management options. Girl, I don't know about you, but I right away thought, I don't know that I ever in my own life, and I guess this is a question that I have for you because I know you don't represent the entire Black community, but you're a woman of faith. I don't know that I ever thought like, I trust God, therefore I'm not gonna pursue medical intervention. So I just don't know that I like that they posed the faithfulness of Black communities being why they don't pursue prophylactic mastectomies or medication. I kind of want to say it's because those things, I mean, that we have data that shows Black women aren't treated per guideline. That has nothing to do with faith. That has to do with the way people are treating Black women with cancer. So I don't know, maybe in the last minute talk about that, and maybe it hit you differently, but for me, that's how it hit me. And then we'll conclude with what the recommendations from this study were. They gave 3 recommendations of how we could build equity among these populations.
So I was intrigued by that faith piece as well. I thought, wow, they included that in the study. That was very interesting. So it must have been very impactful. And so let me play devil's advocate. So I do believe that the Black population do cleave more to their faith and less with science. I do believe that there's more of a trust in God than a trust in doctors. Now, part of the education that we have to do is to say, hey, especially you and I as women of faith, you can trust science and trust God too, because God can heal through science. I had this conversation yesterday. I said, in the Bible, the Apostle Paul, who wrote 1/3 of the Bible, had a doctor named Luke traveling with him. Now, he has healed many people himself, raised someone from the dead, but why did he need a doctor to be his traveling companion? Why did he have an issue that couldn't be solved by, with prayers? So there is not, this, if I have faith, I can't have science. They can both coexist. And that's, again, another cultural thing that has to be addressed with the population.
So interesting. So it's not even just interesting, it's encouraging that if we find ways that communicate who we are holistically with each other, there's keys in there that help us communicate how we reach these outcomes. So we'll close with the findings of the study, the suggestions from the findings of the study. So the lead author said, among the possibilities to build equity within healthcare for this population, find better ways to acknowledge and incorporate patients' spirituality and religious perspectives into discussion about prevention. That's exactly what you were just saying. Ensure that women have access to good insurance coverage or other ways of paying for specialist care. And improve training. I loved this at the primary care level. I mean, we just did another program on primary care to oncology because so many times primary care doctors stay with you and your family for years, for decades. Yes. So improve training for primary care physicians who are often the sole source of medical counsel for high-risk Black women living with or after a cancer diagnosis. Very cool article. Very cool article. Any takeaways from you, Sharon?
Well, I'm just, when I heard those last 3 recommendations, I was thinking, we are already starting that process at Total Health. And so I'm excited about the future. I'm excited about what the impact that we are going to make. I know that we may just be one company, but I believe that we have the wherewithal, truthfully, to really make a big dent in this problem.
Yeah, I agree with you. I think, we're the largest provider of free oncology education in the US. We're already reaching the physician groups, the nurse groups, the provider APP and nurse practitioner and PA groups. We have phenomenal relationships with advocacy organizations where we get to not only include their voice on our podium so that providers can hear the patient experience, which is something that really is completely underutilized. But we also get the opportunity to share with advocacy what clinical updates, data updates, et cetera, affect their groups of patients. So I feel like we sit in such a central seat
Yes.
to be able to disseminate this kind of information, plus doing things like this, getting together with you for tea times.
Yes.
Today, my tea time was a decaf coffee in a plastic cup. But okay, well, Sharon, I love meeting with you like this. I hope this is helpful for our audiences. Share it with people. Let it be a place where you start discussion. And Sharon, if you want, you can leave us with one positive thing that you have for this day that you're clutching onto this Wednesday hump day that we can leave for our Tea Talk audience.
Well, I was reading your post about your talk at the school this morning, and you had a basket of fruit, and you said that this was nature's medicine. So motivated and inspired by that, I went and I made a smoothie with bananas and all of nature's best. And I said, this is medicine. So my word to the audience today is nature's fruit is good medicine.
Yes, it is. Thank you so much. Thank you, everyone. Have a great rest of your Wednesday, and we'll see you tomorrow when we're joined with a breast medical oncologist who can probably answer some of these risk questions and maybe give us some insight as to how she talks with patients when she seeks out color in her practice.
Awesome.
Thank you all so much.
See you tomorrow, guys.
Okay.